young by our standards, and he's having chest pain, which sounds like a typical symptoms, right? His EKG shows ST elevations, which is a typical finding on the EKG of a heart attack. And obviously you're out there in the woods, you don't have any blood tests back, but he's already got 2 out of the 3 findings, right? And like I said earlier, that's what it takes to make the diagnosis. So he's got a heart attack. So the next thing is to figure out what do we have to do to treat him, all right? So if you have a blocked artery, which is what's causing a heart attack, what do you think the treatment's gonna be?
Unblock it.
Unblock the artery, right? It's not rocket science. It's plumbing, okay? So that's basically, if you remember nothing else about how you treat a heart attack, the bottom line is you take a blocked artery, you gotta unblock it, and you gotta do it as fast as possible. Because the longer it's blocked, the less heart muscle can be recovered. Yeah.
The medication, the Vascular or something, what does that?
That's a medicine to reduce your cholesterol. So that goes back to the actual progression of cholesterol narrowings and atherosclerosis. Okay? All right, so how do we treat it? So I titled this slide, Heart Attack Therapy Made Ridiculously Simple, because it is really, really simple at its core. Right? We talked about it. If it's caused by being blocked by the blood clot, the treatment would be unblock the artery. Okay? And how that can be done is with really 2 main techniques. One is with medicine, so you can sort of dissolve the clot from within. The other is to blast open the clot with some other kind of treatment. Yeah.
So medication would be the first step, but if it's severe enough, you just go straight to the
It's actually, so every patient who has a heart attack will get medicines to thin their blood and so on. Aspirin, you've seen the commercials, you know, it's the wonder drug that works wonders. Aspirin is very, very important to that because it blocks the blood's platelets and helps them sort of break apart. And about 15% of heart attacks actually might be treated with aspirin alone. The artery might open just with aspirin. There's other blood thinners, but the majority of patients, well over 70%, will need something else done to treat the heart attack. And the medicines are really more potent clot-busting drugs, which we're not going to talk about a whole lot because in the United States, that's not the standard of care. The standard of care here, by and large, especially if you live between university hospitals and Cleveland Clinic, is to get an angioplasty. Yeah.
When you say blast it open, do you just like build the pressure until it?
Not quite, but I'm going to show you. I have some of the gizmos here that we use to do it, and I'll show you an example. And if you want to see it in real life, come down to the cath lab and we'll show you. Okay, so this first angiogram, let's see if we can put this to play. Can you guys see that? Maybe we can shut the lights off just for a second. Lights switch on. Where's it in front of you? You got it? Okay. Yeah, that's a little bit easier. Okay, so this is a patient, when they first come to the cardiac cath lab, what we do is we shoot an angiogram. And here what you see on the left panel is a catheter like this. Okay, looks like a straw. Try not to flip everything over. But this straw, we thread up from the patient's groin, okay? From here, like this. And we put that up all the way up into the heart. And we inject dye through that. I'm sorry?
That's big.
We'll see how big you think it really is. It's a lot better than getting your sternum sawed open with a bypass surgery. So you can see in the left side, these are the left-sided arteries, the left main artery, the left anterior descending, which is up top here, and the left circumflex. And this is the right coronary artery. You can see, unlike these arteries, which kind of taper like the branches of a tree, this artery stops abruptly right there.
It has that big
blockage.
Right. I'm sorry?
It has that little, like, when it first began, that right there.
Is
So
there?
this is the very beginning of the artery, but then it stops right there. Right? Really, this artery should come all the way down like this.
Is there blood leaking out of that, like that mist?
This is actually just the dye going back into the aorta, because it can't go forward down the artery, so it goes back backwards, basically. Okay? So that's the blockage, and that's the heart attack artery. Okay? So, what do we do about that?
Not all of them.
What we do is we unblock it. Let's see. So, do I have any volunteers? You're up front. Come on up here.
You think John?
His heart definitely is big.
Don't worry, I'm not going to put any catheters in. Okay? Lie down right here. Yeah.
They gonna break your
Take
table.
the table's fine.
Watch your head.
All right. So here's what we do. Okay? You let your legs hang. There's an artery right here called the femoral artery, right in your leg. You can also go from the wrist. Okay? It's called a radial. Okay? What we do is we put in a catheter. This is the catheter. I'll pass these around, like I said to you earlier. These catheters are 2 millimeters in diameter. So yeah, it looks big to you from back there, but it's only 2 millimeters in diameter. Okay? So this catheter is going to get threaded up like this from here, and we can control the catheter by turning it. So see, with my right hand, I'm twisting the catheter, and you can see that this is how the catheter will move in space. Because I've done lots of these, I kind of know which direction I need to turn the catheter to get it to sit in the coronary artery. Okay? Once we get there, you're going to take a wire. Okay, this is the wire that we use. Now, it might be hard to see because it's only 14 thousandths of an inch. But this wire then gets threaded through this catheter all the way up across the blockage. Okay? And then over this wire, we're going to take a balloon. So imagine you're sitting there awake. We're going to give you pain medicine for your chest pain to make you relax. And so that you don't freak out when we put these catheters into you.
You just put me out.
I'm sorry?
You just put me out.
It's actually safer for you not to be put out totally. Because when you get put under general anesthesia, you're not breathing on your own anymore. So there's complications potentially that can happen because of that.
Can they feel it travel up?
Pardon me?
Can they feel it?
You really, except for the initial needle puncture where we actually put a needle in, especially if we put it down in your groin and it's going to be uncomfortable. We give you, don't worry, I won't be touching you. But the initial Novocaine injection that we give, just like when you go to the dentist, will sting a little bit, and then it doesn't really feel like anything. You might feel pressure like I'm pushing on you, okay? So imagine we then take this catheter, which is a balloon catheter. All right, this catheter has a very small balloon on the end of it, and we connect it up to one of these devices, which is basically a fancy bicycle pump, okay? And you stick this on here, and you actually, somebody will turn the dial on the back of this, which will raise the pressure inside the balloon, okay? And then the balloon will inflate. And that's how you unblock the artery, okay? Yeah.
But doesn't the block just travel until it reaches another point?
It's interesting. What we do is we basically squash it up into the sides of the artery, and generally speaking, it doesn't want to, fly forward. It actually will, because of all the blood thinners in the bloodstream. Once you squash it open, it'll stay open. So that's how we do it. So all of this is happening while you're lying down, and the catheters that get put into you are only this big. And when the procedure is over, we can close up the spot where we went in, and the patient can sit up and essentially, well, not quite walk off the table, but we'll be able to get on a stretcher and get right to their bed. If we go from the wrist, which is an increasingly popular way to do this, the patient can literally walk off the table and go to the intensive care unit to be monitored. Yeah. Does it hurt? It doesn't necessarily hurt, except for when we first go in, and when we put the balloon up and we inflate the balloon, blocking the artery temporarily. So patients might have an intensification of their chest pain.
Can it break the artery?
It can.
Oh.
Can you rupture the artery? You can.
What happens if that happens?
If that happens, then there's ways we have to seal the artery from within.
Oh, God.
But sometimes,
Just take care of yourself.
sometimes
Just kill me.
in less than 1 in 10,000 patients, you might need to have emergency heart surgery.
That happened.
And that's when they cut open the sternum.
That's right.
Eric. That happened. Just kill
All
me.
right, so that's the graphic demonstration. That's the graphic demonstration of what we do. But that whole process happens from the time the patient comes into the cath lab to the time the artery is open, usually happens inside of 10 minutes. From the puncture in the skin to the time the artery is open. All right, happens very, very quickly. Almost as quickly as what we just described to you, okay? And the reason for that is that we practice to do it as fast as possible because the less time that it takes, the more muscle will be recovered. Yeah.
For example, if you have small veins,
Mhm.
then it's best to go slow.
Well, right, that's actually a good point. The arteries in the wrist can be smaller than the arteries in the leg, not surprisingly. And so if we're not confident that these arteries are big enough for even these small catheters, but I can tell you that even the smallest of you in here would probably have no problem getting this catheter into your wrist. Okay? I can tell you from experience. All right, so let's talk about reperfusion. Okay? You've had a demonstration of what we do for reperfusion, but basically perfusion means blood flow to the heart muscle. Reperfusion means restoration of blood flow that's been blocked. Okay? So this is the first critical concept. The most important treatment in heart attack is reperfusion, which is restoring blood flow. And the perfusion is, as you know, the blood flow brings oxygen to the heart muscle. And without the oxygen, the heart muscle cells will die, and that's why you have myocardial infarction. So you want to reverse that as soon as possible to minimize the damage. Okay, we talked about the medicines, okay? Medical reperfusion happens with clot-busting drugs, okay? And thrombus is another word for blood clot. Lysis is a word for dissolve. So thrombolysis is dissolving a blood clot with medicines, okay? We use drugs like TPA and streptokinase, and actually in the entire world, the #1 treatment for heart attack for a totally blocked artery is with medications. Because in many places, they don't have cath labs to do procedures like we do here. So they need to treat with medicines, and these are very, very effective. But what do you think the risk of this procedure would be if you're giving a very potent clot-busting drug?
It's gonna be hot.
Your blood won't clot, and what happens then?
If you start to
Bleed.
bleed,
If you start to bleed.
Yeah, you bleed. And about 1% of patients who get these medicines will die because of bleeding. Okay? So obviously the risk of dying from a heart attack is greater than 1%. So that's the calculation. It's more risky to have a heart attack that's not treated. So they give the medicine, but about 1% of patients will have life-threatening bleeding. And ideally, you give it in 30 minutes from the time you make the diagnosis. Yeah.
So would you say that age is a great risk factor in heart attacks? Because like the examples that you were giving us, like if they have a heart attack right there, it seems minor, but you said it's not depending on the person. But do you think that age causes things down?
Well, so age is a risk factor for heart disease because as you get older, the blockages generally get worse. And when I said that patients have a heart attack in the jaw, that doesn't mean their heart attack is happening in the jaw. The heart attack is happening in the heart, right? It's the symptoms are being felt in the jaw, right? So patients who have symptoms can have symptoms all over their bodies: stomach, chest, arms, jaw, whatever. But the bottom line is that whatever's going on, business is going on in the heart muscle, okay? And it's really hard to predict how bad the heart attack is just based on their symptoms. And age is a risk factor for heart disease because as you get older, the blockages tend to get narrower. Okay? So mechanical reperfusion is when you actually try to open the artery the way I just described to you guys, okay, with something like an angioplasty. The first type of treatment for this was actually to saw open the chest and take a vein out of your leg and put in what's called a bypass graft. So instead of trying to go through the artery and open the artery blockage, they would actually just take a vein or some other kind of graft material, which is basically a tube that they sew in to go around the blockage. Okay, it's like, imagine you have a street that's blocked with snow and the snow plows haven't gone through, but the snow plows have gone through the side streets. You take the side streets to get around the area that's blocked. It's the same idea here. You take a vein out of the leg, put it in as a bypass, but to do that requires open heart surgery, which takes a lot longer. And the likelihood that you're going to save the heart muscle from the heart attack is much lower because it just takes much longer. Yeah.
So how do you take the vein out of the leg to put in the heart?
Yeah, so they actually will make a surgical incision, usually on the inner side of the thigh. And there's a vein, you have duplicated veins. You have multiple veins that drain the same area in the legs. So they can easily take one of them without compromising the vein, venous return from the legs. So they take, typically it's a vein called a saphenous vein that runs on the inside of the thigh. And they take that out and they use that, it's about this long, and they can cut it into sections to make as many bypasses as they need.